Hello, I'm Dr. Jennifer Klemp. I'm a professor of medicine in the Division of Medical Oncology at the University of Kansas Cancer Center. I am also our Director of Cancer Survivorship. Today, I'm excited to talk with you about cancer survivorship clinic development and implementation. Here are my disclosures. And I think one of the places I'd like to start, just because I want us to right size our conversation, is really talking about who are cancer survivors. And we are going to use the traditional definition from the time of diagnosis through the lifespan. And that also includes caregivers, family members, and so forth. So that means as you're conceptualizing program development, expanding your program, you may start with a smaller scope. Maybe it's just post-treatment survivors, or maybe it's patients with a lower risk. But we need to think about, from our bigger picture standpoint or our larger program development standpoint, all of our survivors, those living with and through their cancer, those who may be at high risk for recurrence. They're going to need a different level of risk stratification and management than patients who have early stage disease and have minimal treatment. Patients who are diagnosed or have metastatic disease, they will require treatment for the rest of their lifespan. So how are we managing those survivorship issues with these different buckets of survivors, or where they are across the continuum? Adding kind of to that complexity is this slide, which I'm sure many of you have seen, but it's actually called the silver tsunami. So not only do we have that increasing number of cancer survivors, but as you can see here, 2/3 are over 65. Over 65 means that they have 2, 3, 4 comorbid conditions, most of those being things like hypertension or other cardiovascular risk factors, diabetes, being overweight. So when we're thinking about our cancer survivors, we also need to be thinking about, well, what did they walk in the door with? What did our cancer treatments potentially accelerate? And what are the common late and long-term effects of the treatment that we've given? And how would those comorbid conditions interact with those pre-existing or other risk factors that our patients are experiencing? Also, just to reinforce, though, our oldest population and our youngest, those two quartiles that are sort of the bookends, are still your highest risk groups. So if you were going to narrow down to a certain population, you could always start with, younger survivors and thinking about things like fertility or bone health or cardiovascular disease. Similar to an older population, cardiovascular disease would also be a target. So really trying to put that into perspective. So this slide is something that I have used actually since 2006. So it is an oldie but a goodie. And it really has helped us anchor kind of how we conceptualize survivorship, how we build our program, and how we deliver service across the cancer control continuum. So if we use, once again, that definition of survivorship beginning at the time of diagnosis, we know that navigation and kind of guiding your way through this cancer experience is a priority for all of our patients, and they need different levels of navigation and different levels of support. So that's why understanding what their needs are, doing a risk assessment is really important. We also know that pretty much every patient needs some sort of biomarker or germline or somatic testing. My practice for over 20 years has been cancer genetics, so I am a huge, obviously, proponent for improving our workflows to do more point of service genetic assessment, and really making sure we have those improved and updated workflows for both germline, somatic, and other types of biomarker testing. We know that we need to understand kind of what's going to go into their treatment plan, and that means we need to know what those comorbid conditions are. These roundabouts are very purposeful. Some patients never leave that treatment phase of care. Some patients will leave and come back, and some patients will go on to long-term continuity. So as you're thinking about your practice, how are we embedding patients within the clinic? How do we maybe have a freestanding or well survivor clinic? What are the different buckets that really make sense? And I know in our practice, we've tried multiple different kind of ways to deliver survivorship care, but the most effective is that for the high put through, we do have standalone clinics for breast cancer survivors. However, most cancer survivors are seen by APPs within the clinic that they practice with their collaborating physicians or other cancer care team members. So embedding it within the clinic has really been the most effective for buy-in, for continuity, and really for delivering overall high quality survivorship care. And so it's our job also to understand kind of, okay, well, what are these treatments we're giving the patients? What are those baseline comorbid conditions? How do we determine, once again, kind of which of these clinical challenges is the greatest risk to the patient? And I've added IOs here because really, you know, as that's emerging and as we're learning more about the acute and more extended late effects of IO, we need to put all this in perspective, because it's very rare that patients who are receiving chemotherapy or other types of adjuvant therapy really get a single modality. Those are early stage, maybe surgery only. And so most of our patients are a little more complex. And so we have to think about this bigger picture. And we need to, as we're thinking about those contributing factors, think about it from two buckets. Is this an issue that happens during treatment and will persist, like cognitive impairment, fatigue? There are a variety of things that happen during the treatment phase. Some can persist and some will resolve. And then we have the late effects bucket. What are things we need to be educating and empowering patients to pay attention to, and collaborating providers that can happen 6 months, 5 years, 20 years down the road? So we need to put this into the whole person, right? Head to toe, brains, bones, heart, you know, hormones, all that good stuff. And so we need a stepwise process to be able to put this into context. So this is a tool that I would tell you really, as you're sharpening your tools, building or growing your survivorship program, this needs to be very clearly delineated. How are we doing that baseline risk assessment? How are we educating our patients and our teammates so that we can really have that all hands on deck approach? What's the ongoing process? So sure, you can assess them at baseline, but you need other time points that make sense per disease state, per needs that you've identified in the patient. And do you have effective interventions? I just really have a problem when we do these needs assessments, or we do a comprehensive risk assessment. We identify opportunities, but we don't have those next steps. So anything that we're asking about, anything that we are hoping to assess and manage in our patients, we do need to have virtual, in-person, community-based, some sort of intervention or resource available to the patient. NCCN continues to update their survivorship guidelines. These are key facets of survivorship care. This is a whole lot of stuff to deal with in a 20-minute, 30-minute visit. So it really kind of needs to be embedded within the process. Patients need to be empowered about what to look for and what to share with us, maybe through patient-reported outcomes. And then what about things that aren't in these guidelines, but are still issues, such as fear of reoccurrence and employment and financial toxicity, which really are two of kind of the greatest concerns for many of our patients. And that really came to light during COVID. So we need to develop, and this is really the key kind of focus of the rest of our discussion, we need to develop risk stratified care. We cannot deliver one size fits all to everyone. Not only does not everyone need that level of care, but we don't have the bandwidth to be able to deliver that level of care. So we need an approach that allows us to assess the patient's needs and the complexity of their needs. And then how do we put that into practice? How do we use collaborators, shared care partners, and other cancer care team members? And what types of interventions do we have available, or what are those gaps? And so that really helps us put our patients into buckets. And this goes right into sort of a genetic framework, but what are kind of the patients who are low risk or average type risk? What about moderate risk? And then those at high risk. And based on those needs, and it could be psychosocial needs, could be financial needs, it could be risk of reoccurrence or risk of late effects. Whatever that need is, based on the treatment that they received, plus those other complex factors, needs to help guide us in putting them in a bucket to allocate resources and interventions appropriately. And this isn't meant to overwhelm you, like, really, you want me to do all these risk assessments? It's meant more to anchor that we can't just do risk assessment at one time point. And maybe a patient comes to us at a different time point. So we need to have a process to be able to meet the patient where they are and to be able to assess them preferably obviously at baseline, but then at what time points across their continuum? How do they feel comfortable engaging with us? So it's not just a one-sided street of us asking them questions. We actually have, a two-way street where there's that bi-directional conversation. And knowing, and how do we know in a pretty rapid fire way, what treatments go into which buckets? Because our first risk stratifier is the diagnosis and the treatment that the patient was given. They're in our cancer center. That's why we're still engaging with them. All those other complex factors add to it, but our first stratifier is, okay, the patient had breast cancer, the patient had colon cancer. What type of treatment, what type of surgery, what type of ongoing therapy are they engaged in? And so by starting with understanding the risks associated with the treatment and the diagnosis, it will help you initially put them into a bucket. And then knowing, okay, well, based on a moderate risk, we want to follow the patient a little bit more closely. We want to do these types of tests. And then you're engaging the patient, and then you're documenting that appropriately based on the patient's level of risk. So putting that into context, you want to have a process. And I think a 3-step process works, right? You're going to have your risk assessment. How do you want to do your intake? Do you want to include a patient-reported outcome? If you have the patient complete something, you need to coach them, teach them, educate them on how to complete that tool and how to engage the patient. Otherwise, the patient can be a little bit passive. You need to make sure you have the right types of educational tools that fit not only with the patient population that you're seeing, but really meet the health literacy of the patient sitting in front of you. So asking those questions about, how do you learn? Are you a visual learner? How do you make these big decisions in your life and other healthcare decisions? And understanding kind of that shared decision-making framework so you can help guide the conversation and guide the patient's next steps. And then what are those next steps look like? What are those interventions? Do you want to continue using a survivorship care plan? Do you want to use more of an order set or a to-do list? And how do you role delineate? Here's what we're doing. Here's what you need to do. Here's what are your shared care partners in primary care or other specialties. This is their responsibility. So how do we have these referral paths built, and how do we really build out that program? So taking this to kind of that final step, by putting them into the low, moderate, and high risk buckets, we're able to define our risk stratification a little bit more. We're able to engage the patient and understand how the complex comorbid conditions affect that patient and their decision-making. And then we need to take our toolbox and inventory it. What do we have in there? How are we using our navigation resources? How are we getting patients, kind of along their journey? Do we have kind of that directory of services that may be internal, so we know how to get patients to the fertility specialist or the cardio-oncologist? And those pathways need to work. They can't take you 15 minutes in clinic to try to get patients in to see someone. We need to have both patient and provider, so kind of all stakeholder education, and we have to optimize our electronic health records. Survivorship is not scalable without optimization of the EMR. And I will say that over and over, because that is absolutely true. You only have so much bandwidth. Your time is best spent with the patient. So if we do not optimize our technology, we will not succeed at implementing high quality survivorship care. So these components of survivorship care have really changed over time. It started with the Commission on Cancer saying, hey, everybody needs a care plan, to now we need to demonstrate how we deliver survivorship care. So you may still use a care plan. It should, obviously highlight prevention, risk of recurrence. What are those late effects to look for? How are we assessing psychosocial and physical late effects? How are we coordinating that care? And pretty much all of our professional organizations highlight this as a priority, but then how do we actualize it? Because we know the challenges of delivering a care plan, which are numerous. It's very expensive, it's very time consuming, and really has very little data to support how it impacts overall healthcare. But it's costly because it takes a lot of time, and studies have shown anywhere from 40 to 60 minutes on average to complete a care plan. So that's not realistic. And that's why technology optimization is essential. And that's why we really have to figure out what's best for our patient population and for our team that we're working with. And role delineation is a huge part of that. We either take on too much primary care or we try to assume that primary care is being done, but we need to role delineate. And I will tell you that one of the things that we've added into our care plan that was very helpful is who's doing what. If you're going to be the one seeing a patient every year and ordering a mammogram for the first 5 years, then you would take responsibility and put that into kind of that to-do list or that order set. But you have to remember that a primary care has a gazillion competing priorities. So if you want them to do something, they are totally cool with you saying, hey, primary care, these are your 5 things. These are my 5 things. And that is very acceptable. It needs to happen, and we need to make sure that we are effectively role delineating. And then how do we engage that survivor? That's really an untapped, unutilized part of the care team. And sometimes they have the least amount of skills or the least amount of health literacy tools, but we have to get them engaged because this process works so much better if we have an engaged patient, if we have an engaged caregiver. So it does take a village. It takes all of us understanding our roles, and it doesn't mean that every patient needs every one of these specialists or services, but it means that as part of our program, we need to make sure that we have those resources available to us. And this is a recent figure off the National Cancer Institute's Office of Cancer Survivorship, and I think it takes sort of that village, and it breaks it down into what does the village actually need to deploy. So we know what types of partners and experts we need to have available. And here's sort of that more comprehensive list of what needs to be accomplished using that village and really being able to hone in on health maintenance and health behaviors, special populations and disparities, really taking it to that next level. So I really like this slide, and these slides will be available to you so you have that as a resource. So in a lot of our work, we've tried to really identify these cross-cutting themes of patient-provider engagement, knowledge gaps, access to survivorship care and resources, and then the organizational structure. These are huge in primary care as well as in oncology. And so I think these cross-cutting issues and themes need to be addressed. It gives us a place to start to bridge those gaps. And I think that, as we get better at delivering more continuity or extended survivorship care, we have to depend on these partners, and our partners need to be empowered to be part of that process. And I think this was really helpful for us in identifying what gaps we needed to address locally and really tap into our great shared care partners, but how do we make them more of an effective member of the team? So the last member of the team is that survivor. How do we engage them? How do we keep them, kind of understanding their roles and responsibilities? Here's their roles and responsibilities. They need to do their screenings, attend their appointments, take their meds. And if they're not, we need to encourage them and empower them to tell us why. We need to think about genetics and all along the way, lifestyle modification, smoking cessation, nutrition, and all the things that they can do from their vantage point, in particular dealing with health behaviors and health screenings. So please make sure that you're giving them those instructions. Those can be pretty standardized. However, there's going to be special limitations or unique situations with certain patient populations. So having a resource available, especially dealing with lifestyle sort of down, will really help you enhance your care and engage your survivor. This is a list of sort of those final key stakeholders and challenges, based on the key stakeholders we have, from patient to provider to our system to the organization. What are the challenges and how do we tackle those? So I wanted to include this because I think it's a nice resource for you, relatively new as well, to help you, empower you to be able to tackle or take this resource back and say, hey, we aren't optimizing our EMR, and we're not going to be able to do this across the board, across our 5 locations, across our 1 location, if we don't have some standardization and if we're not really effectively using our technology. So please, use these to strengthen your argument and to kind of frame your development or your growth as you're deploying and implementing new survivorship strategies. So I want to thank you for your time today. This growing population needs us to prioritize risk all along the way. We have to understand that these patients are complex and should be looked at as sort of a chronic care management. And we need to have that role delineation so that everyone in the care team is effectively managing and working from their scope of practice to deliver high quality survivorship care. So thank you again for your time and enjoy the rest of the conference.